Hello, and welcome to the Boston Structural Heart course. In this new program, we will be presenting a series of presentations relating to basic and advanced concepts in perioperative transesophageal echocardiography. These presentations are targeted and designed for fellows completing the accredited cardiac anesthesia fellowships. And the reason I made this presentation was that I have recently reviewed a lot of transesophageal echoes performed in the operating room and was amazed to find the lack of any systematic approach and despite being called as comprehensive but being anything but comprehensive. What was missing most importantly was a workflow and a minimum set of images and a minimum set of standards that are supposed to be met during an intraoperative echocardiographic examination. So in this presentation, I have started from the very basic, from what I think and what I assume should be known prior to entering the operating room to perform a comprehensive TE examination. And in this first presentation, we'll go over the workflow of a perioperative transesophageal echocardiographic examination. Enjoy. Welcome to our fellowship lecture series. In this presentation 1, we will go over the workflow, that is the protocol and conduct of a comprehensive intraoperative two-dimensional transesophageal echocardiographic examination. We will restrict ourselves only to the two-dimensional echocardiographic examination because the 3D and more advanced aspects of this examination will be addressed in a later presentation. This presentation is not a substitute for the core knowledge needed to understand echocardiography. You need to read texts and journals for that. It cannot be used as an alternative to actual performance of transesophageal echo. You need to do that either in the skills lab or the operating rooms. This will attempt to prepare you and establish your readiness to perform your first clinical transesophageal echo examination. And this presentation is a detailed workflow of an intraoperative TE examination. In this specific class, the trainees will be able to outline principles of ultrasound physics that are important for ultrasound machine operation and machine controls, illustrate the components of a comprehensive intraoperative TE examination, acquire echocardiographic images, analyze qualitative and quantitative information, compose a diagnostic echocardiographic report, and communicate information methodically and effectively. What this course covers is the workflow of a comprehensive intraoperative TE examination. Now, what is workflow? This is technically defined as a series of sequential steps necessary to complete a process. In any invasive clinical procedure, there are two components of proficiency. First is cognitive knowledge, and the second is manual dexterity. And what workflow does, it puts together and ties your cognitive knowledge with your manual dexterity. Each of them is equally important. That's why we have put one number on each of them. There's no second thing in it. So knowledge of workflow puts together your cognitive knowledge and your manual dexterity to perform a series of sequential steps necessary to complete the process of a comprehensive intraoperative TE examination. And this is not how your first day of TE rotation is supposed to look like. The fellows are trying to use stereoscopic lenses to see a stereoscopic screen and appreciate three-dimensional echocardiography in real time. This is not what your first day should look like. Your first day should be spent in the decontamination room seeing how the TE probes are processed when they come back from a clinical use in the operating room. How's the leak test performed? What consists of a decontaminator? What's the temperature? And how do we ensure the safety of TE probe when it goes through a decontamination process? You should be able to not only clean the TE probe, you should know where to store this thing, and what are the most important steps involved in the safe handling of the TE probe after it has been removed from the esophagus and being ready for the next clinical transesophageal echo examination. As you can see in this one, I was amazed to find out that most of the fellows and clinicians do not know how to perform a TE test. This is one of our chief cardiac anesthesia techs performing an actual TE probe cleaning and a leak test. While we'll go in the detailed workflow of a leak test and a safe handling of TE probe in the decontamination room, But as you can see, that this is a pretty complicated process. And one of the competencies of the National Board of Echocardiography, and as well as for the delineated in the guidelines by the American Society of Echocardiography, and that is performing the safety of the equipment and the ability to perform and check an electric leak current test in a transesophageal echo probe. I will scrub through this long video to demonstrate the various steps that are involved in this very complicated and integral component of our clinical TE examination, in which various probes are inserted and various checks and balances are performed to see that there's no clinical electrical leakage of current from the TE probe which can damage the esophagus and can endanger patient safety. So, having given you this perspective of why we are doing this thing and why we need to know the workflow for TE examination, let's go over a little brief history of transesophageal echocardiography. Now, the first and clinical use of transesophageal echocardiography was in UCSF with Dr. Frazeen, where they developed transesophageal an esophageal stethoscope as an adjunct to transthoracic echoes. This was supposed to be used for patients who had COPDs, barrel chests, and had challenging transthoracic windows, but the problem was that the size of the probe was so enormous that there was an incredible amount of gagging and coughing by the patients, and they had significant discomfort during and after the procedure. So they did in about 30 patients and abandoned the procedure, and this series was published in Circulation in 1976. In around the same idea, in Albert Einstein College of Medicine, Dr. Yasuoka's fellow Masayuki Matsumoto from Hiroshima in Japan was trying to develop an epicardial stethoscope to measure cardiac function and dimensions during cardiac surgery. Now, the problem was that this was a process that led to interruption of surgery. There was a risk of breakage of the sterile field and prolonged the surgery while in the operating room. So it was not a very popular idea. So while this was abandoned due to discomfort, but Dr. Yasuoka and Dr. Matsumoto combined and looked at their own epicardial probe, which was much smaller in size, and combined that with the esophageal delivery device developed by Dr. Frazeen, and that's how they were able to go around the problem of interrupting the surgery and were able to do intraoperative transesophageal echocardiographic examinations without interrupting the surgery, or for that matter, prolonging the procedure and risking sterile breakage and all the other problems that were associated with it. And then they published their results in the American College of Cardiology in 1980, and further timeline involves development of an MOT probe attached to a bronchoscope, electronic phased array transducer, which will go in the physics section of what a phased array transducer is. However, the most important and interesting thing is that the initial use of transesophageal echocardiography in the operating room related to its use for as a wall motion abnormality tool, and not during cardiac surgery as a procedural adjunct that it later evolved to become. So the further development, when manufacturers and the commercial people jumped in with the development of a biplane TE probe that I used clinically when I was a resident and fellow. Then the multiplane probe came in the late 1990s, and followed by the demonstration of the first application of three-dimensional echocardiography with Dr. Pandian at the Tufts Medical Center in Boston. And therefore, this is a story of curiosity and innovation to solve a very complicated problem, and that is of looking at the myocardial walls. In the intraoperative use of transesophageal echo, the anesthesiologists were initially the first time classified as perioperative echocardiographers when the practice guidelines for transesophageal echo was published in anesthesiology in 1996, and that was the first time they laid down the cognitive skills, the indications, contraindications, and the levels of expertise at various levels. And I had the privilege of putting together this article in the Heart Journal that related to evolution of transesophageal echocardiography. And if you look through the history of development and innovations in transesophageal echo, you'll be amazed to find that it was purely a monitoring modality in the operating room, initially for high-risk vessel surgery, and then later on evolved becoming a vital and a critical procedural adjunct during structural heart disease and other cardiac surgical interventions. And if you look at the evolution of structural heart disease interventions, you can see that they were limited and to only arrhythmia-related access to the left atrium, and T was used for guidance, so at best, occlusion of left atrial appendage devices, but only after the development and clinical use of real-time three-dimensional echocardiography that the structural heart disease interventions have literally exploded, not only in numbers but also in complexity, and now the most complicated intracardiac interventions can be performed by the real-time guidance of three-dimensional echocardiography. However, let's coming back to the intraoperative use of transesophageal echo. If you look at the ballpark of the range of expectations our involvement in the monitoring of the patient, is purely number one is for qualitative function, which I call eyeballing. Then a quantitative aspect of our involvement, which we call providing numbers, that's ventricular function, valve structure and function. And then a very important and complicated process, and that's the rescue transesophageal echo, in which we are able to provide real-time and ready availability of a diagnosis in a life-threatening hypoxia and hypotension. And finally, as a procedural adjunct for percutaneous catheters, minimally invasive cardiac surgery, and that is to provide procedural guidance during these interventions. However, the word comprehensive implies and means containing nearly all aspects of something. Now, intraoperative transesophageal echocardiographic examination, when called comprehensive, has to be involved in all of these aspects of intraoperative examination. And there are multiple aspects to it. People classify it in different fashions. That involves both looking at the structure and function, a systolic and a diastolic examination, 2D, 3D, diagnostic or monitoring, and there are various names for this comprehensive echocardiographic examination. However, one thing is for certain, the misconception that it doesn't start with pressing the acquire button on the machine. You have to know a lot of stuff before you get to the machine and are able to press the acquire button, and it doesn't start over there. There's a lot more that we need to do before that. And image acquisition is only part of it, because there are multiple steps to get to that point. And echocardiography is not just a monitoring tool, I just said. It is a vital procedural adjunct, and we provide some critical information both for cardiac surgeons as well as interventional cardiologists, which is critical, and we cannot be wrong over here. So the truth that a comprehensive echocardiographic examination in the operating room goes beyond pressing simply the acquire button. And there is an entire workflow to it, a complete process before you get to the point where you do an actual intraoperative TE examination. And what I call this process consisting of 4 steps. Number 1 is to have a knowledge of the logistics of the intraoperative exam that consists of knowledge of the physics of echo, instruments, and how to set them up. Then comes the acquisition part, which has to be comprehensive, sometimes focused, and has to be goal-oriented to provide a critical diagnosis and a decision-making adjunct. Then comes the interpretation, which can be qualitative, quantitative, and the ability to communicate those results effectively in a goal-oriented fashion to the cardiac surgeons and cardiologists. And lastly is archiving, which means you have to store the raw data, the 2D and 3D information, for the ability to be retrieved at a later portion so that you can actually perform a review and as well as quality assurance of the exams that you perform. So it consists of logistics, acquisition, interpretation, and archiving. If any of these steps is missing in this examination, then I do not consider that as a comprehensive echocardiographic examination. So for image acquisition, manual dexterity skills will be acquired in the skills lab and the operating room. This is not learned on the YouTube, and this is not learned watching presentations. You need to actually do the examination and look at the images to be facile at performance as well as interpretation. So the resource documents, which are absolutely essential for anyone starting to do comprehensive intraoperative examination, are American Study of Echocardiography guidelines for both general and procedure specific, and they are a must-read. Before you actually go and touch the probe, you have to have a knowledge of what these guidelines state. I'll briefly go over, first of all, the guidelines of American Study of Echocardiography in performing a comprehensive TE examination. These are recommendations from both the ASE as well as the Society of Cardiovascular Anesthesiologists. Now, it relates different levels of performance, basic and advanced, and director level, both by the ASE, SCA, the ACC, the Canadian Society of Anesthesiologists, as well as the European societies. But what we are concerned is this specific portion that I've highlighted, with this red box, and that is the one that have been put forward by ASE and co-endorsed by the Society of Cardiovascular Anesthesiologists. And the end of your fellowship, this is where you will stand. This is the number of exams that you need to be involved in, the number that you have to be personally having performed, the CME credits for maintenance of certifications, and a detailed aspect of what you should be knowing and doing over the next 1 year. This also, as you can see, lays down the cognitive skills required for competence in adult transesophageal echo. And as you can see, the first part, when I went over this thing knowing the knowledge of infection control measures and electrical safety issues related to the use of transesophageal echo. So this is this standard, and this thing, something not that I've made up. This is an expectation of an echocardiographer in performing comprehensive transesophageal echo to know the electrical safety, the disinfection and cleaning of transesophageal echo probes also, in addition to knowing a lot of other stuff. So this just, point being that just doesn't start with making pressing the acquire button and coming in the operating room and putting on stereoscopic glasses here. So looking at the basic cognitive skills are knowledge of physical principles of echocardiography, for image formation, blood flow velocity measurements, instrument settings. That's an incredibly important part of a comprehensive intraoperative echo examination. Knowledge of cardiac anatomy, of course, that's a no-brainer. Knowledge of the pathological changes, again, you have to be able to appreciate abnormalities if you want to be involved in the intraoperative echo room. Finally, knowledge of fluid dynamics, knowing the Bernoulli equation, the continuity equation, and principles of flow convergence, as well as formation of contraction jets and turbulence in the vessels and in stenotic valves. And finally, knowledge of pathological changes in blood flow due to acquired heart disease as well as congenital heart disease. This is again required for competence specifically in perioperative echocardiography. This is in addition to what you should know, alternative diagnostic modalities, normal cardiovascular anatomy, and also commonly blood flow velocity profiles by Doppler echocardiography, which means you should be able to use Doppler to diagnose regurgitation. You should be able to diagnose, stenosis and other normal and abnormal ventricular function. This is additive to what was already, delineated in the last slide. So the technical skills needed to perform a perioperative echocardiography at an advanced levels are all those that are required for basic and additional technical skills that relate to interpretation of pathological conditions and specifically use of transesophageal echocardiography in guiding placements of intracardiac cannulas for mechanically circulatory assist devices as well as minimally invasive cardiac surgery. Now, first step before you put a transesophageal echo probe in anyone's esophagus is to know the absolute and relative contraindications which involve absolute as being perforated viscous esophageal stricture, esophageal tumor, perforation, laceration, diverticulum, and upper GI bleed. Now, sorry about that. So we go to the next slide after this, and also knowing what the complications that relate to perioperative and diagnostic transesophageal echo are. As you can see, there's more complications for diagnostic echo because this is generally performed sometimes in patients who are coagulopathic and patients who are on anticoagulation medications. So diagnostic TEEs is, as a matter of fact, a little bit more hazardous as opposed to perioperative transesophageal echoes because patients are already screened and kind of buffed up when they undergo cardiac surgery. So another very important publication for cardiac anesthesia fellows is the guidelines for use of transesophageal echocardiography to assist with surgical decision making in the operating room. Now, this guideline is complementary to the ones that is the comprehensive guidelines for transesophageal echo and relates, as you can see in this next slide, very, very importantly, of the various views and transesophageal echo modalities of Doppler and color flow Doppler that are required for a specific disease entity. For example, evaluation of mitral valve anatomy, what do you need to do? Evaluation of MS and MR severity, specific things that and specific views and specific echo modalities that you need to provide, as well as linear measures relating to, likelihood of repair failure, dynamic LVOT obstruction, specifically in case of mitral valve. But it goes in a comprehensive detail of every possible scenario what transesophageal echo could be used for in the operating room. And hence, it's an incredible resource for cardiac anesthesia fellows and is a must read in the early part of their fellowship when they're starting on with the skill sets for transesophageal echocardiography. Now let's get to the bottom line in this presentation, and the outline will be that we'll go over basic physics, which is very practical, that relates to machine operation, that we obviously will transition on to instrument settings, image acquisition, interpretation, and finally upload and archiving. And these are going to be some broad presentations, a series of presentations, and this is too detailed a topic to overgo in just about one presentation. So basic ultrasound physics, that being one of the most important things that we need to know, a certain set of core principles that we need to know, and building blocks that we need to be very cognizant of before we go and do a transesophageal echo examination. So let's just look at an image and what do all these signs mean. I often put this image in front of cardiac anesthesia fellows and ask them what each of these specific numbers means. For example, the one over here, the P off button over here. What is these TI, SO 0.2 and MI 0.6? What does this triangle mean? And of course, what this is for. And I'm quite amazed that most people can tell something sometimes about the focus or kind of the T probe that they're using, that is X72 T probe. But beyond that, most people do not know what these numbers exactly mean. And that's kind of sad, because a lot of very important information that relates to this echo image is outside the viewing field of this image. So next question, is this image appropriately adjusted? I mean, can you guess what this person is, or this echocardiographer is trying to see, and has he made all the necessary adjustments in the machine to optimize what they really want to visualize in this image? So that's an important thing. So we go on to the next one. Let's compare these two identical machine settings. This is an X7-2T probe, X8-2T probe, 15 centimeter depth, two-dimensional imaging. This is all setting immediately seems to be the same. The focus, TS, TI, SO2, everything is all pretty much the same. But if you kind of look at it a little bit more closely, and you see that in one image, the frame rate is about 63 hertz, and in the other one, it's 40 hertz. Is there any particular reason for these two images to be different? And when you ask this question, first of all, most people miss what this number means. And secondly, if specifically asked, what machine adjustment has been changed to achieve this change in number, whether rightfully or not so rightfully, whether it's required or it's not required, but most people do not know that. Again, now let's go on to this kind of very busy and intimidating slide, looking at two machine settings of a specific ultrasound system. And as you can see, that this is a very intimidating slide, where there's a lot of numbers, and each one of them has a very specific and a very critical meaning for interpretation and image acquisition. And believe it or not, but most people do not know what these numbers mean, and they simply go by the manufacturer settings, and when the machine gets turned on, whatever's out there, they just use that as for looking at a specific structure. And that's because there's a bunch of ultrasound systems. If you look at, there are a bunch of ultrasound systems, and their consoles differ a lot from each other. And there can be an incredible number of knobs and controls, which can be confusing. And they deliberately are kind of confusing because each specific manufacturer wishes to distinguish themselves from the other one. And rather than simplifying ultrasound systems for the purpose of the end user convenience, they are just designed to be manufacturer specific, and that so that you are unable to apply that knowledge to another system. So they don't make it easy to use another system, because whether this is deliberate or is it subconsciously something that is done, I don't know. But this is something which is very confusing and hampers the workflow and cross compatibility of systems. And that's why it's important to know the basic physics, because basic physics does not change, where the consoles and all these buttons and knobs on any ultrasound system keep changing. So if you design your exam simply based on the way a certain specific knob works, then you may be out of luck, because in the next revision of the system, that may not be happening. And therefore, it's important to know the physics of ultrasounds, because if you know the physics, then you can play the knobs as best to your advantage as you possibly can. So what I call as the building blocks and core principles of physics, these are those specific elements of physics knowledge that you have to know before you go and do a transesophageal echo examination in the operating room. That is, image basic physics that is required for image optimization. You have to have a basic knowledge of Doppler to measure gradients, use of color flow Doppler, not only for regurgitation severity, but also to assess flow convergence for stenosis. Then quantitative echocardiography, that at minimally you should know the applications and the derivation of the Bernoulli's equation as well as continuity equation. So these are, those building blocks and core principles that we think should be known to an echocardiographer when they go on to do a comprehensive intraoperative exam. Now let's get to the meat of the presentation, and that's why this basic physics is so important. Because the basic physics tends to answer the two most important questions. Number one is, what do you want to see, and how well do you want to see? These are the two most important questions. Number one, what do you want to see, and how well do you want to see? Let's just say the first important thing, what do you want to see? Is it superficial or deep? Is it static or mobile? Is it something that we want to locate or we want to avoid in this our image? So all these require a certain specific understanding of the machine principle based on basic physics. Now, what do you want to see? The superficial versus deep is very simple. The depth of penetration is determined by frequency, and there's an inverse relationship, which means the higher the frequency, the less of the depth of penetration, which means for a superficial structure, you need to use a higher frequency of transducer or the higher frequency range of the transducer. And if you want to look at a deeper structure, you use a lower frequency transducer or the lower end frequency of that specific transducer. How well you want to see is a little bit more complicated, and that's you need to know where it's located, whether it's moving or is it static, or you want to locate in a larger field of view and you do not know where exactly this object or this reflector that you want to see is thing. So your location, motion, and field of view are the most important things in what you see. Now let's get to the location part first. This is technically defined as a precise position in space. Where is this reflector located? And that's location, and that's called spatial resolution. So how good you want to see something is essentially spatial resolution, which is of three kinds. Number one being the axial resolution, which is your ability to see structures front to backwards, and this is determined by your spatial pulse length. And if the distance between front to back between two reflectors is less than the spatial pulse length, they will be seen as a single reflector, as is the case here. So for them to be seen as two separate reflectors, faithfully produced as two separate reflectors, the distance between them has to be more than the spatial pulse length. The second spatial resolution is the lateral resolution, which is your ability to identify two structures lying side by side, and that's when two objects are closer than the beam width and they're seen as a single object. So that's lateral resolution, which is best at the focal point when the beam is the narrowest, and that's determined by the focus. And the same goes for elevation resolution, because the assumption is that the beam stays narrow, razor sharp, and razor narrow, but it tends to diverge over time as it travels into the tissues, and therefore objects above and below can also be seen and be produced by the system to be within the scan plane. So that's called elevation resolution, and by looking at the graphic on the lateral resolution, you can see that it would be the best at where we have the narrowest beam, and that again, elevation resolution is best at the focal point. So frequency is, a determinant of the spatial pulse length, and focus is determinant of the narrowest point of the beam. So frequency, spatial pulse length, and focus determine the axial, lateral, and the elevation resolution of a transducer. Now, spatial resolution is purely line density. So the number of total lines for a certain transducer is constant, or not constant. The upper limit is constant. So you can either reduce the number for a given sector, or you can increase the density of the line by reducing the sector size. So the upper limit is fixed, the number can be reduced, and the density can be changed. Number can be reduced by dialing down the number of scan lines, and the density can be changed by reducing the sector size for the same number of lines, so that increases line density, or increasing the sector size for the same number of lines, reducing the line density. So reduction of sector size, line density increases. By corollary, if you increase the sector size, line density decreases. So axial resolution as a whole is a function of the spatial pulse length, as well as the lateral resolution being the line density, how far apart those lines are with each other. Now the focal zone that we talk about is the narrowest portion of the ultrasound beam. If you can look at this anatomy of the ultrasound beam, it is pretty wide, almost as wide as the faceplate of the transducer. Then it progressively narrows to the focal point, and up to the focal point is the near zone. And the far zone, or the Fraunhofer zone, starts from the focal point within the focal zone to the later part of the beam. So the focal point is the narrowest, and the half of the focal zone is the near beam, and half the focal zone is in the far zone. So this is where you have the best lateral and elevational resolution. There's a certain part of the focus which is electronic focusing, which is inherent to the system, that cannot be changed, and there's manual focus, which can be changed. Some of the the later systems have a fully focused beam, and that's when we go to the more advanced portions of physics workshop, you'll get to know that. And they do not have any provision of manual change in focus. So the lateral and elevational resolutions are best at the focal zone. Now, how fast you want to see purely is called temporal resolution, and the speed of sound being constant, it is purely a determinant of the imaging depth, which means where is the reflector located in the beam that you want to image in relations to its motion in space, and that's will be determined by the go-return time of the ultrasound beam. The longer it takes for an ultrasound beam to travel and come back, the lower will be the temporal resolution, or your inability to appreciate accurately motion in space. So frame rate of an ultrasound represents the temporal resolution, and the most important determinant of frame rate or temporal resolution is the imaging depth. Temporal resolution is best at shallow images, for a single focus, narrow sector, and low line density, because you have less information to compute, and hence you have a higher ability to appreciate motion. Temporal resolution deteriorates for deeper imaging because go return time is longer, there's multiple focal points, there's a wide sector and high line density because, again, you have more information to compute. How much, on the other hand, is simply an ability of sector size. If you want to see too much, you want to take a panoramic shot of a city, you'll have to take the panoramic shot of a city. Your field of view will certainly be wide, but at the same time, your ability to two-point discrimination, that's your spatial resolution, and accurately appreciate motion in space will be limited. So this brings us to the first holy triangle of image. That's what I call the holy triangle of image, and that is what is what? Spatial resolution is line density, temporal resolution is frame rate, and sector size is your field of view. So like everything else in life, you can't have best of everything. When you're imaging something, you have to decide what is the most important thing for you. Is it the sector size? Is it the spatial resolution? Or is it the temporal resolution? Because based on what you want, you'll have to optimize one of the three things and compromise on the quality of the other two. This is, if you have remembered anything, this is the first thing to remember, and that's the first holy triangle of imaging. That is, what do you want to see, how good you want to see, and how fast you want to see determines your first machine setting based on ultrasound physics that we will just go in about a second. So the holy triangle number one is how much, how fast, and how good. If you remember anything of this presentation so far, this would be the one to remember. So let's go over some practical examples of this physics-based machine operation of the application of the principles of first holy triangle of imaging in image optimization. So let's look at these two images, which is video A and video B. They have the same depth, machine settings, and everything else, except for the fact that video A has a higher frame rate of 53 Hertz as opposed to 40 Hertz for video B. So the situation here is the sector size is the same. Video A has a higher frame rate. Now let's interpret this image in relations to our first holy triangle of imaging. You can see that they have the same sector size. However, video A has a higher frame rate. For the same sector size, video A has a higher frame rate, which implies if video A has a lower line density. By corollary, which means by having a lower spatial resolution, a lower temporal resolution for the same sector size, video B has a better spatial resolution, which means if you compromise your spatial resolution, as in video A, you achieve a higher frame rate, and if spatial resolution is more important to you, you have a higher line density for the same sector size, and hence you'll have a lower frame rate, which means for the same sector size, lower line density and a higher line density in this situation. Now let's look at this frame rate and holy triangle of imaging one more time. You have a video with 53 Hertz, with 66 Hertz for the same line density, and which implies that in this one we are optimized for speed, and in this one we are optimized for resolution over here. Quite to the contrary, for the same settings, you realize we have 79 Hertz. But if you look at these two videos closely, our sector size is less than both these two videos, which implies that you can improve your spatial or your temporal resolution even more by reducing the sector size. So in this one, we have essentially reduced the sector size to achieve even higher frame rate. So this one has low line density. This has a higher line density. Lower line density videos has a higher frame rate. Higher line density videos has a lower frame rate. Let's take a look at it one more time. So on a Philips machine, there's this setting called resolution or speed. Resolution implies spatial resolution, and speed implies your frame rate. Unfortunately, I don't know why they use these terms, but this implies resolution and this implies speed. For the resolution one, you see the frame rate over here in this one is about 53 Hertz. So in this one, the frame rate is 53 Hertz. Now in this video, as you can see, the frame rate is 66 Hertz. So for this video, we have moved the dial on the machine to the resolution point, that the operator has changed this setting to optimize your resolution, which is your line density, and therefore you have a lower frame rate. Whereas in this video, you can see it has been changed to speed, and therefore you have a higher frame rate of 66 Hertz. As you can see in this situation, the dial has been turned all the way to speed function. So using this one, if you go back to this video one more time, and you can see for 53 Hertz, same sector size and every other setting, we have a frame rate of 66 Hertz, because in this one, we have a higher line density because we have chosen resolution as opposed to speed, and in this one, we have chosen speed as opposed to resolution. So you can see that how we can change these things to suit our specific imaging requirement. Another practical example of spatial resolution, temporal resolution, and balanced imaging based on these three frame settings. In this one, the frame rate is 53 Hertz. In this one, the frame rate is 43 Hertz. And in this one, the frame rate is 63 Hertz for the same sector size. In this one, we have put our machine setting of resolution to speed smack in the middle to have kind of best of everything. If you look at it with this holy triangle of imaging perspective, this one, that is the one with 53 Hertz, we want almost best of everything. So we put this setting for the same sector size between resolution and speed. In this situation, we wanted a higher line density and a better spatial resolution. So we moved the knob control all the way to resolution. And in this situation, we wanted how fast, and therefore we moved the knob control all the way to temporal resolution. So for the same sector size, you can see we have changed the machine setting to suit what I want. I want to see the best of everything, so I have to get compromise on everything. This is where I optimize my line density or spatial resolution, and therefore my frame rate goes down. And this one, the frame rate or the motion, appreciation of motion is more important for me. So I change it all the way to this side and reduce my line density for the same sector size. Now, if you go to another manufacturer, that is the GE systems, unfortunately, it's just the differences in knobology. On the GE system console, you have to see this specific control, which says frame rate here. Now, this essentially is by increasing the frame rate, that is your temporal resolution, you're automatically reducing your line density. This is the same control, but just simply means a different thing, which means as you're increasing your frame rate, you're optimizing your setting to the speed function, which means you're reducing line density as you are increasing your frame rate. And as you reduce your frame rate, you're increasing your ability to appreciate location in space, that is increasing your line density and therefore reducing your frame rate. So dialing up the frame rate will lower the line density automatically. It's essentially the same control, but simple, different nomenclature and a question of semantics to distinguish yourself from one manufacturer to another. So to reiterate and reinforce holy triangle of imaging, number one is based on how much how fast, and how good we want to see things. Now, let's go to the superficial versus deep situation. Now, that will bring us to our second thing that we thought initially was very simple based on, just changing the frequency of the transducer. For a superficial structure, like we said, we used a higher frequency transducer. For a deeper structure, we used a lower frequency because we wanted higher penetration into the tissues. So let's look at this again with a practical example. Now, this is a mid-esophageal long axis view of a mitral valve prolapse. And as you can see, have you ever thought about this triangle every now and then? You see this one with something else highlighted, something else circled, but nobody really understands, majority of the people, or what it exactly means, So the G stands for general imaging, P for penetration mode, and R for resolution mode. As you can see, the P, that is penetration, is associated with a lower number, and that's the frequency range of that transducer. And this is the R mode, that is the resolution mode, is associated with a higher frequency, and general is something in the middle, which means you can either choose to view something superficial with a higher resolution, and that's visualize something deeper with a lower resolution, and that's using the lower frequency range of the transducer. Or you want to use something of a higher frequency and therefore compromise on your penetration and just visualize something very superficial with a higher frequency transducer. So this is your holy triangle of imaging number 2, which tells you what do you want to see and how far do you want to see. So general imaging mode is somewhere between the resolution and the penetration mode. The penetration mode is the lower range of the frequency, therefore you want to image something deep, and the resolution mode is something which uses the higher frequency range of the triangle and therefore something superficial. And now this is something that can be used with or without harmonics. Now brings the question of what are harmonics? But we'll get to that later, but let's get this resolution penetration adjustment for a different manufacturer, and that is the GE system, because the previous setting was for the Philips system. When you look at the GE system, you look at this control, which says frequency and octave. So this dial can choose the lower frequency, which will be more penetration, and as you move this dial from this side to this side, you're using a higher frequency and therefore less penetration. Now, they tend to call the harmonics as octaves. I don't know why they do that, but this is, again, another attempt to distinguish yourself from the other manufacturer. Therefore, a lower frequency range would be more penetration. With looking at the Philips system, this would be the penetration mode because you are the lowest frequency right now. And at this end of the spectrum, you have the highest resolution and the lowest penetration using the higher range of this transducer. So now brings the question, what are harmonics? What are they? How are they produced? And their advantages and disadvantages. So harmonic imaging is a physical principle of ultrasound. Don't ask me how it happens, but this is the way it does. And that is, harmonic imaging is defined as creation of an image from sound reflections at twice the frequency of the transmitted waves, which implies it is a physical property of the sound waves that when they are higher power, higher amplitude waves, they tend to get distorted by a non-linear behavior of the ultrasound, which means you transmit a sound wave which is 5 megahertz, but some of the reflected waves are twice the frequency or sometimes 3 times the frequency, and that's called the first and the second harmonic, and therefore you have the ability to create an image from a higher frequency reflected wave and therefore allegedly of a better resolution. So fundamental image is produced by those sound waves which are processing of reflections that have the same frequency as the transmitted wave, and the harmonic waves are created by processing of reflections that are twice the transmitted wave. And when you press the harmonic button on a machine, what you're doing is you're simply increasing, number one, the output power of the system, because for harmonics to be created, the sound has to have a certain amount of amplitude. And then you also change the image creation, not solely on the ones images created not from the fundamental waves that are transmitted, but from the harmonic waves and therefore of a higher frequency. So one downside of the using harmonics is that your output, that is your exposure to ultrasound, increases. So this is essentially based on nonlinear behavior and created by distortion of waves during reflection, and the first harmonic generally being twice the frequency of the transmitted wave, and your ability to create an image with these harmonics is referred to as harmonic imaging. As you can see, this is the transmitted wave, this is the filtered one, which is based on the fundamental waves, and this is the harmonic waves, which we tend to use for image creation when we press the harmonics button. The harmonics are tissue harmonics that are created during transmission, again during nonlinear behavior, created in the superficial tissues and likely to be created along the main axis. Contrast harmonics, on the other hand, are based on using contrast material, which are gas-filled bubbles that are injected into intracardiac cavities, and when they are struck by the ultrasound beams, they free vibrate and cause distortion and generate first and second degree harmonics that relate to better delineation of the endocardial surfaces, intracardiac tumors, and therefore, or cavity delineation as a whole. And again, they relate to mechanical index, which means the higher the power of the ultrasound wave, the more will be the tissue or contrast harmonics. Let's get to a practical example of something. So if you want to have a regular imaging, you can see in this one, in video A, that we have something which is set to G imaging, which is a balance between resolution and penetration. Right? So this is video A is regular imaging, whereas video B, I have moved the control to penetration mode over here, which means you can see the apex a little bit better than you can see in either of these tubes. So which means we are on penetration mode and using the lower range of frequency for this transducer. And this is for something like LV apex if you want to see that. For superficial structure, when I don't, penetration and visualizing deeper structure is not something that I'm interested in, I will use the R mode, which means the higher range of frequency of this transducer to see a shorter distance of penetration and also to see something better, such as mitral valve. And you can see subtly that the appreciation of mitral valve in this one is slightly better than the one in the other two videos. So that's kind of the practical example of using either one of them. Now we can combine these two holy waves, holy triangles of imaging into optimizing what we want to see. For example, in this one, we have moved to G imaging, which means balance between penetration and resolution, and dialed the holy triangle number 1 to speed mode to get a frame rate of 66 Hertz. In this situation, I'm still balanced between penetration and resolution, but I want to take a better look at structures of their position in space. Therefore, I compromise on my frame rate by dialing it to all the way to resolution. Now in this one, I want kind of even higher frame rate. And as you can see that I have reduced the sector size, I'm still on the G mode, that is between penetration and resolution, and dialed the control to entirely speed mode. In this situation, you can see that we have gone on to penetration mode, looking at the apex better with a higher speed. So based on these things, you can change and manipulate these two holy triangles of imaging to achieve what you want. How fast, how good the field of view, and at the same time compromise between penetration and resolution. And then again, you can compromise each one of them with or without the use of harmonics, with the caveat being that using harmonics will lead to a higher exposure of ultrasound and more rise in temperature. For example, in this one, holy triangle number 1 is to speed, so we have 63 Hertz. We have general imaging mode, and we have employed harmonics for this one. So therefore, by having this dotted line in this holy triangle of imaging number 1 implies that we are using harmonics. So these variables within these two triangles can be used to optimize your image and customize your machine setting to what you want to achieve. So this brings us to the holy triangle number 2 to finalize it. That would be a balanced image between resolution and penetration. If you move to this spectrum of triangle, you'll optimize penetration, which means you will have a higher penetration to tissues with a lower frequency transducer. And if you want to optimize your resolution, you'll be using a high frequency transducer and therefore less penetration into the tissues and a higher resolution. So therefore, there are multiple methods to optimize an image. It really is the image optimization or the machine settings that are based on physics can be changed to optimize what do you want to see and how well you want to see. So the most important things are how much, how fast, and how good, and how deep, how superficial you want to see any structure. Another example. So let's just say this is a patient presents with mitral regurgitation. This was for a patient from mitral clip. And we needed to localize and visualize the flail segment. We start off with a frame rate of about 40 hertz. We are on the holy triangle of imaging number 1. We have the focus set exactly. We have reduced the depth. And we want to see not only a better image, but also how fast it is moving. For this one, was initially set at penetration using harmonics. So what is the imaging requirement in this specific situation? We need precision in position. We need precision in motion. Sector size is not important because we know exactly where this flail segment is located, and that's the point in the entire image that we want to concentrate on. So step 1, we change to speed preference mode and increased the frame rate from 40 to 63 hertz. That was number 1. So significant increase in frame rate, as you can see, from 40 to 63. Next step, we change the sector size and change the elevation of sector size to bring our frame rate from 118 to eventually 122 megahertz to go as far as, by reducing the imaging depth and changing using the holy triangle of imaging number 1 to change our machine settings to the speed mode. And you can see that from 40 to 122 hertz, we have essentially tripled our frame rate to visualize the location as well as the precise motion of this vegetation or a flail segment. And our frame rate has significantly increased in this situation. So this was to resolution mode, and as soon as we changed it to speed mode, it went on to 122 hertz. So step 1 was reducing the depth, changing the setting to speed mode, and then reducing the sector size to almost triple our frame rate to optimize to answer one question, that is the location as well as motion in space, with ignoring the sector size, knowing exactly where this vegetation is located. And that was our final frame rate. So comparison between images from 40 hertz to 122 hertz based on simple changes in machine operation that are geared to give me the specific answer that I want to give at that specific moment in time. So that brings us to the last portion, that is ultrasound safety, and that's this output power control. We've all seen this MI and TIS. These are simply the mechanical index and the thermal index and the ability of ultrasound waves to cause tissue cavitation, that is the mechanical index, and the thermal index, the rise in temperature. Both are increased, that is the thermal index as well as the mechanical index increase by increasing the output power of the system, and the output power increases the power intensity of the system, and or the energy in the ultrasound wave is increased. And that brings us to the Alara Principle, which is as low as reasonably achievable. While this relates more to fetal ultrasound in obstetrics, but it is also good to reduce output exposure even during perioperative echocardiography to reduce this rise in temperature of the TE probe, and has safety concerns for esophageal injury. And we want to have it as low as reasonably achievable. And the dictum is that the image is too dark, you increase the gain first, because that does not increase your output exposure. And if the image is too bright, the step 1 should be reduce the power. Now, increasing the output power increases the energy of the transmitted wave, and therefore improves your signal to noise ratio. There's more signal coming back as opposed to noise. However, the issue with increasing the output power and mechanical index and thermal index is increased exposure, and therefore enhancing your mechanical and thermal index. Receiver gain is simply actually a post reception control, and simply amplifies all the reflected. It's a simple digital amplification of all the reflected signals, and your signal to noise ratio is unchanged because your noise is as much amplified as your signal is. And however, the upside of this thing is that there is no increase in power. So this brings us to the conclusion of the first portion of this presentation. And after this, based on the machine settings, which are based on practical physics, we'll dive a little deeper into more principles of Doppler continuity equation and their practical application during clinical echocardiography. Thank you very much.